The following presentations are meant to lay out a foundation for us as we together begin to look at the priority of the aging HIV community. The first presentation will focus on important research regarding HIV and aging and highlights the psychosocial needs of the older population living with HIV and AIDS. The second looks at HIV and aging from the perspective of a geriatrician, a medical provider who specializes in treating the unique needs of older people. Our first presenter is Stephen Karpiak, PhD, who is the Senior Director for Research on HIV and Aging at GMHC. After 25 years of research in neuroscience and immunology at Columbia University Medical School, he served as Executive Director for HIV/AIDS Homeless Housing Program in Phoenix. He served as Executive Director of Pride Senior Network, which focused on aging LGBT issues, and later joined ACREA in 2002. There, he supervised their clinical trials program and launched ROAR, Research on Older Adults with HIV, and supervised clinical trials for HIV drugs. His research on HIV and aging has been recognized by the U.S. Surgeon General, contributed to the establishment of an HIV and Aging Awareness Day, the White House Conference on HIV and Aging, and U.S. Congress and Senate hearings, literally bringing HIV and aging to the forefront. Stephen is on faculty at NYU Nursing and has published over 150 peer-reviewed scientific papers. He is now co-PI of ROAR 2.0, which he will address during this presentation. Most recently, he received 3 years of funding to establish a web-based national HIV and Aging Resource Center. Our second presenter, Dr. Eugenia Siegler, is the Mason Adams Professor of Geriatric Medicine and Professor of Clinical Medicine at Weill Cornell Medicine. She's Associate Program Director for the Medical Residency at the Weill Cornell campus of the New York Presbyterian Hospital, where she is a teaching attendant and sees geriatric outpatients. She's a geriatrics consultant at New York Public Hospital Weill Cornell's HIV Presbyterian, the Center for Special Studies. In addition, she serves on the Medical Care Criteria Committee for the AIDS Institute Clinical Guidelines Program. After receiving her undergraduate degree from Princeton University, Dr. Siegler obtained her MD from Johns Hopkins. She trained in internal medicine at Bellevue and New York University hospitals, where she was intern, resident, and chief resident. Following residency, Dr. Siegler completed her fellowship in general internal medicine and geriatrics at University of Pennsylvania. Before Dr. Karpiak starts his presentation, which will be the first presentation, we ask that questions be held until after both presenters have gone. I now present to you Dr. Stephen Karpiak.
Good morning. Thank you for that introduction, and thank you to the AIDS Institute for the invitation to present on this critical issue in the epidemic. Their medical care for this population is complex, as Dennis had just mentioned, and what I'd like to do today is kind of go over some of the highlights of why we're here today, how did we get here today with this aging population, and underline some of the critical challenges that they face. Next slide, please. As was said, the incidence of HIV infection is increasing, or at least is a substantial number over the last couple of decades. We're going to cover what it means to have multimorbidity, meaning 2 or more chronic conditions, and what are the risk factors for that occurring, and then to look at some of the psychosocial considerations that this population encounters. I'll discuss some of the data from our ROA-2 study, which is a multi-site study across the USA, and some of the implications. Next slide, please. There is an increasing incidence of HIV infection in the aging population. Next slide, please. And this gives you some of the numbers of prevalence, meaning the number of people over the age of 50 in each of these cities or states across the USA. You can see that the highest number is in San Francisco, which makes a great deal of sense because that's historically where the epidemic began. And New York City, like New York State, is around 54, 56%, and other communities follow. The take-home message here is that the epidemic is being dominated, if you will, by older adults. Next slide, please. This is the percent of people living with HIV over age 50 in New York State. And as was just mentioned, in 2017, we are at 54%. And I'm sure that number is increasing even as we speak. The increase is about 1.5% to 2% a year. Next slide, please. Here is the number of people who receive AIDS diagnosis among those over age 50. And as was mentioned, people who are older adults are at higher risk for having not just an HIV, but a dual diagnosis of HIV and AIDS at the time of detection, which means that they are falling through the cracks, that the testing efforts are not covering this population particularly effectively. Next slide, please. So how do we get here? How do we come about with an aging population? Well, primary in this is effective HIV treatment, ART. This became available in 1995, 96. There are now many medications available, and increasingly as efforts are made to detect people, bring them into care, and put them on medications such that they suppress their viral load and keep the virus from causing a collapse of the immune system, we'll see more and more and more people in the population and aging. There is another source, of course, and those are the new infections that occur every year in older adults over age 50. This population is often neglected. People tend to think that people over 50 don't have engage in sex or substance use, but in fact they do, and in fact this contributes to the overall number. Next slide, please. This is, again, going back to, this is national data, CDC surveillance data. If you just look at the dark red bars and then the purple bars after, you can see that as one increases in age, the likelihood of a HIV diagnosis occurring at the same time as an AIDS diagnosis increases with age. These are substantial numbers, by the way. In 2017, there were about 6,200 new diagnoses over the age of 50. This is not a small number, and we need to address this more if we intend to get to ending this environment, the AIDS epidemic. Next slide, please. So, ACREA has been fortunate to have funding for the last almost 12 years from the New York City Council to, in fact, emphasize and bring to older adults a message about safer sex. It recognizes from those early days, 12 years ago, that older adults, in fact, do engage in sex. In fact, they do so throughout their lifespan, and that they are at risk for getting HIV. There have been many social media campaigns, and if you visit our website, Age is Not a Condom, you'll see those the many posters that have been developed over the last many years. In fact, it's the longest sustained program of HIV prevention for older adults in the USA. The CDC and NIH have really allocated very little money for prevention efforts that target the older adult. So let's take a look at where we're at clinically with this population. This X, this is the kind of slide that statisticians and researchers love, but if we go back and look in 2002, this is the proportion of people with HIV who have died, and in 2002 we see that 65% died from a illness that was related to HIV, and that only about 30% to an illness not related to HIV. And yet today, in 2016, this has reversed itself, so that deaths due to HIV directly are about 30%, and deaths due to something other than HIV-related illnesses is now close to 65%, and that divergence continues. This really defines the clinical demand on clinicians who are treating this population. That whereas in earlier days, getting people down to low viral loads and increasing CD4 counts and sustaining that was the primary function of the primary care physician, the HIV treating physician, the ID doc, those priorities have now shifted. And this is actually another discussion that needs to be had as regards to the workforce that's out there who can manage this aging population. I think Jeannie can talk to that much better than I can. Next slide, please. So from where I stand today, this is just a summary, but by the beginning of the next decade, 70%, which is an amazing number, of all those infected with HIV in the USA will be age 50 and older. Older adults with HIV more often die from non-AIDS illnesses, and primary care providers spend most of their time addressing non-AIDS health issues. Multimorbidity, which indicates 2 or more chronic conditions, is the rule and not the exception in this population. And the management of multimorbidity in the person with HIV is the new challenge, and Dr. Siegler is going to be addressing this directly in the second half of this presentation. Next slide, please. Thank you. So an article published around 2010 used the words "the complication of success." What it described was this enormous success in the treatment of HIV, ART. In fact, many believe that it will be the single most important medical advance in the last century. Taking a infection, a disease that it would lead to an inevitable rapid death sentence, and turning into a long life prognosis for that patient is an amazing achievement. But what we see today as the population ages is the development of multiple chronic conditions that are typically associated with aging. So in that context, here we have a population that's aging, and yes, they are developing illnesses that are associated with aging. We would expect that. And I think a lot of people may not have expected that, having had such an enormous success with ART, antiretroviral therapy. Nonetheless, the list here, cancer and cardiovascular disease, are 2 of the comorbidities we see in this population today. There are of particular concern since they seem to be elevated at higher levels than we might see in a control population. Nonetheless, almost every single comorbid condition one might consider that occurs as one ages, one can add to this list. Next slide, please. So why is this happening? I think there are multiple reasons, but there's one general underlying etiology or hypothesis, and that is that there is increased inflammation in the system, in the body, that occurs because of HIV, but other things as well. And from the day of infection, this inflammatory response of the body, it spikes and stays elevated until the person is put onto antiretroviral therapy treatment. So the treatment does not eliminate the inflammation that occurs because of HIV infection. It only blunts it. It blunts it substantially, but nonetheless, that inflammation is continuing to be there. So think about it for a second. You have, say, a 30-year-old who's infected with HIV, and you have this large increase in inflammatory response in the body, and it can continue until that person is on medication, which we know can be soon or can be prolonged. There can be a great deal of delay in that. So that inflammatory response is blunted by ART, but is not eliminated. By the way, there are many other sources of inflammation in the body, and we should not forget them as well. It's not just inflammation from HIV that we're talking about here today. Next slide, please. So what's the primary risk for multimorbidity in these older adults with HIV? What is it that's causing multimorbidity to be seen in this population? Hint 3, age. We're all aging. Every single one of us in this webinar today, everyone ages. I think some of us would like to see that aging process stopped or at least modified or slowed down, but the reality is it's this inevitable walk up in age. And age is what causes the higher incidence, higher number of multimorbidity diseases to occur as one ages. Next slide, please. We have a very enlightened attendees today. Well, as you heard, there are many risk factors for multimorbidity occurring. And what's important to note here is that many of them, and they're listed here, smoking, for example. When we first did our research on older adults back in 2005, almost 55% were smoking. is a very high number. And if you want to mention any of the diseases we talk about today, smoking is not one of the very highest risk factors. But also history of substance use, historically or presently, alcohol use, poor nutrition. This is a population, as we know, that is socioeconomically deprived. Little or no exercise. Co-infections, Hep C particularly, can increase risk for multimorbidity because of the stressors it places on the body. The cumulative stress of depression and anxiety and other mental illnesses, I can't talk about this enough. This is a population that exhibits 3 to 5 times higher rates of depression as compared to the general population. Those numbers were in existence in the 80s and they exist today. The failure to manage mental health issues in this population is a serious deficit, a serious failure. Many mentioned social isolation. Social isolation has long been known to be a underlying risk factor for multimorbidity or poor health outcomes in the older adult. And yet in this population, social isolation has existed from the very early days of the epidemic, largely driven by AIDS stigma, ageism today. And it is a serious issue. We know that social isolation is one of those factors that also predicts poor health outcomes. How to overcome that social isolation is a serious challenge, and that requires a lot of attention by many, including providers online today. Not working because of the risk of losing health benefits. In many instances, this population, by and large, does not work. Many want to work, and I think that we have to make every effort to do that and bring them back into the workforce, if not on a full-time basis, at least part-time. Work defines the purpose of a person in their life, and many lack this. Obesity, which we're seeing increase in women, is a particular concern, older women. Stigma, we mentioned. I might just, as an aside, say we all know that stigma exists. In fact, if I receive another paper to review on stigma, I generally reject it. Not the paper, but reject reviewing it, because we know about stigma. What are we going to do about it? I think heretofore we talk about it. We need to help the person living with HIV stand up and be counted. Until that happens, stigma will remain with us and remain insidious. Loneliness, which goes along with social isolation, is at very high levels in this population. Being a sexual minority contributes risk, and food scarcity. I know that in GMHC, where we serve at daily meals to almost 350 people, and we have the pantry that has actually a waiting list on it, that the need for food, housing, food, are essential elements of life. And yet this population, in many cases, does not have that access, and they alone contribute to increased risk for multimorbidity. Next slide, please. So here's the question that one always asks, and I get confronted with it when I present. Is this population aging differently? Clearly they are. Clearly they are aging differently because of all these risk factors. But I might mention, all the risk factors that I just listed are not HIV related. They're not HIV specific. They're not caused by the virus. Very few studies have been done which really isolate in a control group the HIV infection alone and can control for all those other, that long list we just went through. It's a very, very hard thing to control for. So there are many who believe we are watching accelerated aging in this population. This remains a debate and remains a hypothesis. But we do know that this population has more and more and more of these comorbidities as compared to anyone else in that population at large. So their health challenge is large. The pill burden, disease burden is considerable in this population. Whether it's directly related to HIV or not, or just by the constellation of characteristics, the psychosocial constellation of this population, that is still open for discussion. Nonetheless, today at hand, we know what we need to do. We need to address all of these risk factors, regardless of where they come from. Next slide, please. So why should we care about this? Well, for many reasons. First of all, because these are human beings that require care. I think about it often. Back in 1995, 96, we had people who were on average age, say 25, 30 years old, and we gave them life. Not we, but those who developed the antiretrovirals and the clinicians who put them out there and treated them with it. And we said, okay, here we're going to literally save your life. And that was the end of the conversation. We did not treat the whole person, but we just treated the effects of the virus. And retrospectively, we complained about that, but we're left with that legacy today. The best indication of that is mental health. We have yet to adequately address an illness, meaning depression or anxiety, and they are illnesses in this population. And we need to redouble our efforts and make that happen. Next slide, please. There's another, if you will, crass reason why we should do this. People who have multimorbidity are on a course or on a path to being placed into long-term healthcare facilities. And many should be, but most should not. And I know that in New York City and New York State, the goal is to have people age at home, which is a better environment and a more positive environment. But the other reason is it's very, very costly for folks to go into long-term healthcare facilities. This data is from California. It shows that when you have a few comorbid conditions, 0, 1, 2, 3, the annual cost per year is below $50,000. Add more, 6, 7, 8, 9, 10, and you go up to close to $250,000 per year. These are massive sums of money. And this is a challenge, not just in the HIV population, but in the other aging populations. And we in fact, for the first time in history, live in an aging population environment. Next slide, please. So, psychosocial considerations. Psychosocial is a broad word. I've recently been talking about psychosocial infrastructure, which we need to talk about more. These are those, if you will, squishy or soft or gray area challenges that often go unnoticed or untreated or unmanaged by our primary care physicians. And geriatricians, you're going to hear from Dr. Siegler shortly, are well aware of this issue, far more than primary care physicians, which is, and Dr. Siegler is going to address this in her presentation. Nonetheless, the importance of, for example, social networks. Our first observation in my research back in 2003-4 was that this population had very poor social networks, meaning they had few friends, they were disenfranchised from family members, excuse me, and from other members of their immediate family environment, and that was created, if you will, this social isolation that occurred. Of course, age stigma was operating here too, and that it's really from our social network that we derive the caregivers that one needs to age successfully. I'm sure many of you online today have been caregivers for spouses, parents, friends. This is a critical part of medical care. And yet, this population likely does not have access to those caregivers. Next slide, please. I went into PubMed and just did a quick search on depression and HIV, and as you can see, there is now an increasing awareness and focus on research on depression and in this HIV population, which is a good thing. Next slide, please. Why depression? Well, depression is kind of like it immobilizes folks. When we did our original study of 1,000 New Yorkers, New York City residents with HIV over the age of 50 back in 2005, we found that 2/3 of them by CSD screen had symptoms of depression. And we know from the literature that depression is one of the prime causes of non-adherence to HIV meds, but all meds, not just HIV meds. And that those folks who are in care, and we hear this all the time, the cascade, the treatment cascade, keeping and sustaining people in care. And yet, their depression, a medical disease, is not well managed. Next slide, please. Next. So this is some data from our original study back in 2005, 2006, and you can see the indications of how these folks are isolated psychosocially. 70%, 70 of the 1,000 people we studied live alone. Actually, this is the exact opposite of what you'd expect in the larger general population, whereas only 30% live alone. Next slide, please. How many have primary relationships, meaning they are married, are spousal, have spouses, or have certain types of marriages back then? Very few, approximately 15% actually had a partner. Partners are important as one ages because they're the ones who remind you to take your meds, pick up your shoes, pick up the rug on the floor. They are important in implementing medical care and prevention measures. Next slide, please. Children. Children are a great source of social support as well as caregiving as one ages. But whereas everyone today thinks since the passage of the Marriage Act, et cetera, that everyone's running out and getting married in the LGBT community. This is not true. It wasn't true then. It's not true now. Only about 20% have children, and in many cases, those children have been disenfranchised from that person. Next slide, please. And this is the data from ROA with my colleague Mark Brennan, who's co-PI in that study and now the present one. And we showed in the study that there are many people in their social network milieu of this population. By the way, we were doing this study before Facebook became popular and social networks became a common phraseology in our language. But you can see here that what's important is not the number of people in your social network, but how many are functional. How many will come to the assistance of that person when they are in need of either emotional or physical day-to-day activity help. And if you look at this, what you find, it's their friends who are the primary source of support for this aging population with HIV. What's disturbing about this is that half of these friends also have HIV. So the reality is that they're going to likely not be 100% available. They would be if they were in good shape physically, mentally, but they're likely not going to be. Again, fragile social networks. Next slide, please. So I was a professor in psychiatry and neurology at Columbia. Mental illness is a clinical condition. It's not something that we just kind of conjure up. It is an illness. It is a disease. And we have to count it as a comorbid condition. More and more research reports now do that. And it's a common occurrence in this population. It cannot be made to go away by not counting it as a chronic condition. Also, there are stressors associated not only with having a mental illness, but also its treatment. And lastly, there are many ways to treat mental illness. Some require the intervention of a clinician or a trained psychotherapist or therapist, etc. But there are also other ways to mitigate mental illness and improve mental health. And some of them are very cost effective. Everything from the support group model to telephone interventions, etc., are being used. We have to think about them because cost is a factor. Next slide, please. One of the other factors that we don't talk about very much, but it's there, is the use of substance use in this population. Older adults did, and many do today, continue to use substances, both legal and illicit. And here is data from the original ROA study, 2005. And you can see that, yes, there are large uses of some of these substances, and many have gone down, but not gone away. They're still here, and they're still part of the makeup of this person. Next slide, please. This, for me, from ROA, was one of the most compelling pieces of data. This was a report of, again, 1,000 people telling us if they were involved in recovery programs. And if anyone's been in recovery or knows friends, family members who are in recovery, these are life-changing processes, and they cannot be minimized. They tell us a great deal about who it is that we are interacting with, not just clinically, but for those of you who provide social services, the whole panoply of wraparound services. Take a look at these numbers. They're very high. Typically, when you ask the general population if you're involved in a recovery program, they're less than 10%. Next slide, please. ROA 2.0 is an extension of the research on older adults, which we did in 2005, and we began to replicate it in 2015. Next slide, please. That effort is characterized by multiple sites where we collect data. That includes the Bay Area, San Francisco, and Oakland, which, by the way, are two very, very different cities, even though they sit next to each other. Chicago, and upstate New York, funded by the AIDS Institute, where we're looking at, for the first time, at a rural population, and in New York City, where we're looking at near 1,000 people again. We are collaborating with Cornell and Dr. Siegler on looking at the characteristics of this population, their needs, and in fact, the Cornell sample alone is going to be paired with their electronic health record, which is going to be an extraordinary opportunity. I might also mention that within New York City sample sits the largest Latino subpopulation that anyone has studied heretofore on older adults. We are just finishing up the Chicago white paper and the Oakland white paper. The San Francisco white paper is out there. If you go to the website, aginghiv.org, you will find those white papers. Next slide, please. This is just the front cover of the San Francisco paper, and I'm going to just present some data just to give you a feeling for the psychosocial elements that came out of this study and will for all the other studies I just mentioned. Next slide, please. This gives you a breakdown of the population in San Francisco, who, by the way, are really quite different when one looks at the national population and New York State, New York City population. This is largely age-wise, they're about right, but they are largely gay white males. Next slide, please. This data was actually very kind of startling almost, but this is the number of people, regardless of gender, who reported childhood sexual abuse. And you can see that the numbers are considerable. In fact, almost 50% report sexual abuse during childhood at some point in their life. This is trauma. We've all heard about trauma-informed care. This is a trauma that most of this population has experienced and carries with them as they move forward, and which has really not been well addressed at all. Next slide, please. These are the number of people who are evidencing PTSD. We have many measures within our research protocol, but suffice to say, if you looked at this overall, about 35% of the older adult populations in these multi-site studies are evidencing PTSD symptoms. Again, evidence of severe trauma having occurred in their life, be it before HIV they were infected or in the beginning stages of it. Next slide, please. Stigma. I mentioned this before. You cannot have a discussion about HIV and aging unless you use and talk about stigma. The reality is that stigma remains alive and well, not only in the general population, but also in those who are aging with HIV. The sad thing is they begin to internalize the stigma. They begin to internalize the myths which stigma propagates. And this is very, very counterproductive and maladaptive behavior. I'm not sure, God knows, how to address stigma, but I do know that we need to help people stand up and be counted. I can't tell you how many times journalists have come to my desk or called me on the phone and said, we want to do an article about older adults with HIV. Who can we talk to? Whose name can we use? And can we take pictures of them? You know what? There are very few people out there who, even to this day, agree to do that. We need to help people stand up and be counted. I might mention that the great advances in LGBTQ rights are done or were accomplished on the shoulders of feminism and this epidemic, AIDS epidemic. It gave visibility to these folks who did stand up and be counted. Next slide, please. When we asked, here's again the San Francisco data, how is your health? Actually, a very valid indication of health status. If you look at the good, excellent good, about 58%. But on the other hand, there's below that, there's about 42% who are not too happy about their physical health and the care they're getting. Those are, again, I think rather startling numbers, particularly from San Francisco. Next slide, please. This is the number of comorbid conditions. These are, I won't dwell on this too long, but suffice to say that the older adult population has high numbers of comorbid conditions, as we mentioned before. The frequency of comorbidity is high in this population. Next slide, please. We asked them about their personal report, self-report, and you can see here they were 69%, 65%, 62% report either anxiety or depression, which tend to coexist, and about 12% have a bipolar disorder. These are 3 to 5 times, even higher than one might see in the larger population. Next slide, please. So, with the aging population with HIV, we see increasing numbers of multimorbidity. Multimorbidity has profound effects on the lifespan and quality of life of these infected people with HIV. Interventions are needed. Infrastructure changes are needed. How we deliver healthcare to them is a challenge and a substantial challenge. And I know that Dr. Siegler is going to address that in the next section. And finally, in one of the processes we went through for the ROA study at multiple sites. We conducted focus groups, New York City, upstate New York, Chicago, Oakland, San Francisco, and other places that are coming on board. And this data, this qualitative data, listening to people talk about living with HIV and aging. And this one quote came out, stands out to almost all of us who are doing this research. Just listen to it. It's sufficient. There are things that are worse than AIDS, like loneliness. It, I think, defines the challenge that is ahead of us. Next slide, please. Also, in that context, at GMHC, we now have multiple programs that are focused on the older adults, some on long-term survivors who are defined to have been infected before 96, before the advent of HAART. And the number of people who are responding to this particular two-day intervention are huge. Last month alone, we had 145 people want to become involved in this intervention. There's a new program that was just awarded to us by the AIDS Institute that does the same kind of intervention except for LGBTQ population or older with HIV. The need is so great, I can't begin to tell you. Being an HIV from a GMHC from a Korea in these last 2 years, because the GMHC services a very large population, like 14,000 clients annually, half of whom are over the age of 50. It's palpable. They really need care. They need help with these wraparound programs significantly. And so many say, we feel like you've abandoned us. And I think that is now the challenge for ASOs, not just here in New York City, New York State, but also across the country. Next slide, please. Thank you. Thank you very much for listening.
Okay. Thank you, Dr. Karpiak, for that very insightful presentation. I've seen your presentation in other forums as well as in preparation for this webinar, and the information really affirms the AIDS Institute commitment to serving this population. So certainly we have not forgotten this population.